Okay, so I'm talking to you about something, it's a bit of an obscure topic, but it's something which will hopefully help you when you are looking at chest x-rays and looking at the lung fields on your films that you'll be looking at. So C-spine, AP C-spines, shoulders, think of T-spines, things like that. And one of the things I always used to struggle with was trying to work out, is this something in the lung I should be doing something about? I'm here looking at MSK features, but I'm aware that this doesn't look right in the lung field. As a chest reporter, I get asked to review films, and they're normally shoulder films, I would say, as a general rule. And it's normally to do with, most cases it will be prominent anterior first costal cartilage junction, which is very broad, very sclerotic, and it creates a sclerotic density in the apex of the lung. And most people look at that and think, oh, that looks a bit dodgy, I need to get some further assistance on that. So I normally get asked questions about that. I get asked questions about pleural thickening, and then people talking about rib anomalies, etc. So I've put together some basic thoughts, really, things for you to keep in mind when you're reporting your MSK films. Don't disregard the chest. Okay, we had a case in a hospital recently in the last 6 weeks where we had a beautiful report on a thoracic spine that was absolutely, on the money, perfect, but didn't mention the large lung tumour that was sat there visible on both views, and they'd just gone in this MSK mode, and the person had given a look, like I said, beautiful report, and the clinical history completely led them down the garden path, and that's the danger. So always appreciate the lung fields, have a good think about them, and if you're not sure, just go and ask somebody. Pull up further imaging if they've had a chest x-ray done 2 weeks ago, 2 months ago, 2 years ago, pull it up. Have a look, allowing for the variation in the technique, your AP shoulder maybe to their PA chest x-ray. And is it there? Can you see it there? Can you make it was there? Is this something that's new, which might be worrying? Or you might be able to look at the chest film from 4 years ago, see it looked pretty much exactly the same, and then you can maybe rest a little easier. Okay, so there's lots of things to think about. It's only an hour. I can't teach you to chest report in an hour. I'm good, but not quite that good. And there's just a few thoughts. And I just want you to think about the lung fields a little bit, that's all. In terms of how people report chest, there's many different ways to look at chest. Some people go from the outside in, so they'll go bony thorax, soft tissues, and work into the mediastinum. I tend to do it the opposite way around. I come in at the trachea at the top, I come down through the mediastinum and assess the mediastinum. Then I go out into the lung fields. Once I'm happy with those, then I start to talk about the ribs and start to talk about the bony thorax and the soft tissues. And I have a fairly standard report. It's, you stick it into Dragon and I'm normal chest, AP chest, PA chest, whatever the combination is, and we set them up as normals. And my standard chest report would be normal cardiac and mediastinal contours, lungs and pleural space are clear, normal bony thorax and soft tissues. And I've reviewed all of those areas. Your brain does it rapidly fast, like it does when you pull a film up. You know pretty much instantly whether this film's normal or abnormal, and then you start to apply your investigative tools. That's my fairly standard chest x-ray report. Here we have a AP chest. AP chest, not fantastic. We get basic information from them. We can't really assess heart size unless it is very, very normal, in which case I think people talk about 60% for a cardiothoracic ratio on an AP chest compared to 50% on a PA chest, i.e. the maximum transverse diameter of the heart should be less than 60% of the maximum transverse diameter of the thoracic cavity. So you can eyeball it, it looks okay. Anything interesting on this film? Okay, we have review areas on a chest x-ray, and the main review areas that we need to look at is behind the heart, because we get the lung fields are obscured behind the heart, and the heart can mask pathology that's sat there in the back of the lung behind the heart, and the lung apices. They are our review areas. The apices are very busy. You've got the first rib, second rib curling round. You've got the clavicle coming across. You might have a bit of apical pleural thickening. You've got the trachea that may or may not be central, depending on if there's any other pathology. Anything concerning you? Well, we're happy that's a normal AP chest x-ray. or it's just after lunch and my brain's still not started working yet because all my blood is going round my belly trying to process my food I've just eaten. The latter, maybe the latter. Okay. The area that I'm getting you to think about is here. We have a normal right lung apex. Remember, the lung fields come about 1.5 centimetres above the clavicle. What do you think to the left lung apex? It's nowhere near as clear, is it? It's not aerated. We can't see lung clearly above there. And this is a nice tumour sat in the lung apex, hidden there in the top of the lung apex. And you might get a shoulder film that's giving you this, and they might have come in with maybe shoulder pain, because classically a Pancoast type tumour will give you radiculopathy, give you symptoms, and the natural reaction from your GP examining you, they'll be thinking you might have degenerative change, you might have some degenerative change in the shoulder, you might have some spondylosis in the neck, and then that becomes their primary diagnosis. In this case, unusual as it is, left lung apex, and this is a Pancoast tumour, okay, or apical tumour. It's just appreciating the difference in density, it's all it is. And if you've got that chest x-ray to go back, you have a look, okay? How about this one? Trauma patient, road traffic accident. I can see I've got my work cut out this afternoon.
Fractured right ribs.
Quite a few of them, yep, fractured right ribs. So we have a rib fracture. Probably that one as well. This one is quite badly displaced, and this one, and probably that one. If we CT them, there's probably even more. There is a phrase with chest, no acute displaced rib fracture, i.e. there can be undisplaced fractures that I just can't see on a plain film. We're going to have to CT them to be sure. Okay, so no acute displaced rib fracture. And then we need to rule out a pneumothorax. With that amount of rib fractures, we need to be thinking pneumothorax. We need to be thinking about anything along those lines. So it's just assessing it. And the periphery of the image, it's classic with an MSK film as well. Whatever information the radiographers present you with, use that. Read it all, look at it all, not just centralising here. Make sure with your sort of search strategy, you do cover all of the film, all of the soft tissues. They can be important and give you tiny clues to what's going on. Okay, we have this clinical history, shoulder pain, question mark, rotator cuff calcification, question mark, arthropathy. That's straight off the request card. Shoulder film. Now you must be comfortable. This is MSK. You're back in your comfort zone. Happy days. So what do we think? Have we got any rotator cuff calcification? And you'll start reviewing the image. You'll start thinking about your subacromial space. Is there any rotator cuff calcification? What's my AC joint doing? Okay, glenohumeral joint. Are we making any diagnoses yet? Anything jumping out? Fairly normal, standard film, happy. Okay. So this patient then came back a few months later, still complaining of pain. So go back to your AP shoulder. There's your lung mass, hidden behind. This was reported as They reported it as no features of rotator cuff calcification, mild degenerative change, slight downsloping of the acromion, blah, blah, blah. Beautiful report for an AP shoulder, but this unfortunately was missed. This patient came, I think it was about 3 months later, large apical tumour. Now it's there, okay, some people spot it straight away, other people you just don't see it, but you've got to start thinking about it. Okay, these do present in that type of manner as well. They've probably been to a physio, CATS or advanced practice physio. They're probably being treated for impingement or something along those lines. So you need to think about the right lung apex. Obviously, I could show you band or abnormal films, but you will spot those easy. This is just to get you thinking about the more subtle pathologies. Okay, so when you get something like that, left lung apex, large mass. Think about the trachea. The trachea can be pushed or pulled. The trachea is a very movable structure. Think about your own trachea. You can move it very easily. It will be pushed or pulled by pathology, and the position of the trachea is important. If you've got a grossly deviated trachea on a shoulder film, you must think about that. Have they got a large thyroid goiter? Is there an anterior mediastinal mass? Why is this trachea indented, pushed over? Why is it pulled towards one side? And when you get this sort of appearance, if this was your shoulder film, I'd be expecting you to have a look at that, the rib density as well. Are the ribs intact? Are the posterior ribs intact? Anterior ribs. You might find you've lost the posterior ribs, which tells you it's a posterior lesion. Okay, so you start to think about that. Also, you might take into account a few more subtleties. Maybe some axillary clips. Maybe it's a breast cancer patient. Might have had a mastectomy. Okay, have we got a destructive bone lesion? Have we got recurrence of the breast cancer? It's about taking all these little things into account.